As we move through the axial skeleton, we're going to move away from the jaw and continue our exploration into the neck, and we'll look at the base of the skull and the cervical spine. We look at the skull itself. We've looked at some of the bones when we looked at the TMJ and some of the movements that are there, but in this particular unit we're going to be looking mostly at the occipital bone, so the base of the skull. And the reason why we're interested in that is because it articulates with the very first cervical vertebra, the atlas, which is C1. Right below the atlas you have the axis, C2, and then as you move down, they're all generally the same, C3 to C7. So we have those four major areas. We have our atlanto-occipital joint, so that's the connection between C0 and C1. C0 is referring to zero, either zero being the first connection, or O for occiput. And then you have your atlanto-axial joint, which is C1, C2, and then you have all your articulations between C3 and C7. The base, or the C3 through C7, the bulk of the cervical spine look like this. This is posterior here, this is anterior, there's your anterior body, this is where your cervical or your spinal disc would be at. Your spinal cord would be floating through here, and then you have your transverse processes, so these that post out to the side, and then you have your spinous process, and these become anchor points for muscles. And then you have the lamina of the vertebra, and this is this empty space where the bulk of the muscles fit in. You have the C1 and C2, which are oddly shaped, and so this is the atlas appropriately named because it's holding the world on its shoulders, in this case the head. And you have these facets here that the condyles articulate with the base of the skull, and then this vertebra sits right on top of this one, and you have the facet joints here, and this sticks right up through this dens here sticks right up through the opening, and C1 is able to rotate amongst it, so we'll look more at that function there. But here is your cervical spine. There's C1, C2, all the way down to C7, and what you can notice as you move down the chain here, C1, C2, that as you move down, the vertebral body gets bigger and bigger and bigger and more pronounced, and this is the tendency that happens all the way down the spine to the sacrum. As you move down, it's bigger load, a bigger base, it's supporting above it. This is your spine stacked. Here's your C1, C2, and you can see how it penetrates all the way up, and as you'll see in another slide, goes right into the base of the skull, and it comes all the way down. You can see how it has a pyramid-like shape where it gets larger as it comes down. But as I said, this is your basic shape, basic structure. You have your body. This is the anterior, posterior. There's your lamina. This is where your spinal cord's at, and all your musculature is right on the outside there. Now, we're going to review this when we look more into the thoracolumbar spine as well, but this is how the vertebrae are stacked on each other. And so they articulate not here in the anterior aspect, right? Everyone's always aware of the disc and herniated, bulging discs, and this is where the movement is. If you're going to look at the axis of rotation, it's going to occur here through this, but the articulation is actually here behind the spinal cord, more towards the pot. And so this is the facet joint, the zygophysial joint. This is the interaction that's happening. And based on how these two bones fit together, that's what allows the movement or the type of motion that's going to be allowed within that area. And it's also a source of dysfunction. So we have the spinal cord running right through here, and you can either have encroachments from the disc itself, or you can have encroachments from bony adaptations from bone spurs and whatnot that are happening here that are putting pressure on the nerve. So it's not always the disc that's causing back problems. It also can be there as well. So you can see that it has a lordotic curve. So if this is anterior, this is posterior, that the curve is going anteriorly, so anteriorly convex or posteriorly concave, depending upon how you're looking at it. Here is your spinous processes, and I just want you to appreciate how far C7 sticks out, and we'll just take note of that now from this view, but we'll talk about it when the slide pops up. So here's a posterior view looking at the C0, C1, C2, and you can see that C2 comes all the way up through C1 and helps stabilize the base of the skull. When you look at the lateral view here, here's your spinous processes, base of your skull. You can see how far that penetrates up. Here's C2, and it goes all the way through C1 into the base of the skull. And then you have your spinous process, and it is pretty prominent. Like, it's right there. Almost all your thoracic spinal spinous processes are prominent, but C7 is the one that's most prominent. You can see that out of all the cervical vertebra. This is also an area that can be injured with weightlifters. It's somewhat sensitive, it's particularly if you're squatting and you have the bar right on the back, where that should kind of be up and above or maybe below. And then you have your nuchal ligament that's right here that runs basically, you can see that prominently through there, that runs from the base of the skull straight down. This serves as an anchor attachment for your trapezius. This is the facet joint that I was talking about. This is where the business is happening. This is the actual joint. The two surfaces are sliding here, and there's movement here as well, but this is the articulating surface. And this, in the cervical spine, these are at about 45 degrees on an oblique plane, so it gives it quite a bit of motion in a triplanar aspect. So both flexion, extension, lateral flexion, and rotation. So it really allows that three-dimensional aspect. Cervical spine has the most degree of freedom, and it has 3 degrees of freedom. It has the most range in all 3 planes. So you can do extension of the cervical spine, you can do flexion of the cervical spine, lateral flexion to the left, lateral flexion to the right, and then left and right cervical rotation. Now these images I just shared with you weren't just exclusively looking at the cervical spine. You have what's called capital movements as well. So you have capital flexion, capital extension. So this is just the head moving relative to the spine, and that's the C0, C1 at that atlantoaxial joint. Then you have what I shared with you, the cervical flexion and extension, which is looking at the cervical spine. And then what you did see, what normally happens, is a combined motion of both capital and cervical aspects. So you're looking at movement through the entire aspect. So this is what capital extension looks like. This is just the C0 rocking back on C1 at the atlantoaxial joint. And this is capital flexion, basically just tucking your chin into your throat. And you compare that with cervical extension, so looking at the entire lower cervical spine moving back, and cervical flexion, where you're lifting your head up off the table or off the floor down to your chest. So chin to the throat is capital flexion, chin to the chest is cervical flexion, most likely a combination of both. And what's happening there, as I had said, is that here's your base of your skull here, the occipital condyle, and during capital flexion you are tucking your chin down, and during capital extension you're just lifting your chin up oh so slightly. You have movement here also in the frontal plane, and so you have left lateral capital flexion, right lateral capital flexion, as opposed to left cervical flexion lateral and right lateral cervical flexion. And again, these movements are, when you bring your head to your side, unless you're really trying to isolate this movement, it's all happening. Now the only thing that could happen, as we'll share, is that you can do counter movements. So you could move the cervical spine, so you can try to bring your ear to your shoulder, and then do capital flexion, try to straighten out your head. So you can move the capital movements independently of the cervical movement. So you have a set of musculature that's doing this, and a set of musculature doing that. So here's cranial cervical, so C0, C1 through 7, cervical extension. You can see the rolling, sliding that's happening here at the atlanto-occipital joint, so C0, C1. You can see at the atlantoaxial joint there is a little bit of tilting, and that the majority of the extension is coming between C2 and C7. So you're getting about 80 degrees total from thoracic spine to base of skull. Look at flexion, same thing. You're getting this tilting at the atlanto-occipital joint. At the atlanto-axial joint. You're getting this rolling and sliding, so the head's tilting down, this capital flexion, and then you're getting a majority of the flexion through the C2 versus C7, and again about 50 degrees through here. This is where you can have independent movement, where if you stick your head forward in protraction, that's cervical flexion, but instead of letting your chin tuck down into your chest, you are lifting your chin up, so you're simultaneously producing cervical flexion and capital extension. When you retract or give yourself a double chin, you are doing cervical extension and capital flexion. The same thing works for the frontal plane. You can bring, like I said, you can bring your ear to your shoulder, so your right ear to your right shoulder, and then tilt your head left as a left capital lateral flexion, and you can keep your eyes level to the horizon as you tilt your head to your right. And so we do that a lot when these areas, the capital and cervical regions, move independently. Again, the movement's happening at the facet joint, and this is just allowing movement to occur and distributing loads, but this is where the movement's at. And so the angle of this facet joint is when it's going to dictate what's available and what's not available. So when we look at the lateral flexion here, you can see that there is a lateral tilting, so right lateral capital flexion. and then you're getting, because of the way that facet joints are sliding on each other, you're able to get about 40 degrees of lateral flexion through C2, C3-7. What you don't see happening at the C1, C2 is you're not seeing any lateral flexion here. So the atlantoaxial joint, so C1, C2, you can do sagittal plane motion and you can do transverse plane motion, but there's no frontal plane motion at the C1, C2. Conversely, when we look at rotation, we'll see here that you see C2 through C7, you're getting a certain amount of cervical rotation, and you're getting almost 50% of your cervical rotation coming from one joint, which is C1 to C2. So at the atlantoaxial joint. What you're not seeing is at the atlanto-occipital joint, C0 to C1 at the base of the skull, no rotation. So the way this is designed is it can't really rotate. It can tilt laterally left and right, and it can tilt forward in the sagittal plane, but the occipital does not move on the atlas in the transverse plane. In the transverse plane, you're getting significant movement between C1, C2, but no movement between C0 and C1. So just keep track of that. All of the joints are involved in flexion and extension in the sagittal plane, but when it comes to frontal plane and transverse plane, you're getting some joints that are available and some joints that are not. So again, here's your C1, C2. This allows rotation in the transverse plane, a significant amount of rotation in the transverse plane, and it allows some motion in the sagittal plane, so flexion and extension, but it has no movement in the frontal plane. And then with the base of the skull sitting on top of C1 here, you get flexion, extension, lateral flexion in the frontal plane, and no rotation. So as we move away from the structure and we look at muscles, we can see that we have some familiarity with some of the muscles that are in the neck. We've talked a lot about the trapezius and the shoulder aspect, and you can see that a lot of the muscles here in the spine do anchor to the scapula. So these come more in play in the thoracic spine. The trapezius, as we kind of think of as a back muscle and an arm muscle, is the second largest muscle of the upper body, third largest muscle in the body. It has a huge moment arm and a big influence on cervical position and the capital position, head position, and cervical spine stability. As we pull some of these layers out, you can see that we get deeper muscles here, and then we get even deeper muscles here that you can see run the entire length down. And as we'll talk about, a lot of the muscles that are coming up are merely divisions of muscles from the thoracolumbar spine. We look at the anterior aspect. We have some superficial musculature here. Again, we can see this platysma, which is basically a skin muscle. This is how you show your teeth. And then we have some familiarity here with the hyoid muscles from the jaw, the anterior neck stability. And then as we go deeper, we have a whole bunch of muscles here that are like the core of the neck. And it's these muscles here that I was referring to that can become weak or dysfunctional over time that force these muscles to stabilize, allowing dispositional or distortions in posture. But our primary muscle of the neck is going to be the sternocleidomastoid, or SCM for short. And you have two heads, a sternal head and clavicular head. And so you can see the sternal head that actually originates at the sternum and the clavicular head that originates at the clavicle. And that comes up and attaches to the mastoid process. And it has a strong lateral aspect, so it's a huge mover in the frontal plane, so it's going to do lateral flexion. But it also comes back. You can see that it has an anterior attachment and a posterior insertion back here, and so it can pull the head forward into flexion if need be, and it's a very powerful rotator, and it does contralateral rotation. In this slide here, we can see that almost 45 degree, it's more like 60 degree, so it's a strong flexor. It can be an extensor depending upon head position, but is a rotator and definitely a strong lateral flexor. It is a superficial muscle, and it's innervated by the same nerve that controls the trapezius. And so you have the trapezius, and we won't look at the lower and middle trap so much, but we're going to focus our attention is on the upper trap. Upper trap has a connection to that nuchal ligament, so it has an influence on all those spinous processes, and then also has a superficial attachment on the occiput, and so it can work with the SCM for cervical rotation. It does contralateral rotation, so the right upper trap will do left head rotation, whereas the SCM, as this muscle is shortened and pulling forward, as the right SCM is doing the same thing, it's doing contralateral cervical rotation or head rotation. So the SCM and trap are agonists in that plane. If we go deeper from the trap, right underneath there, we have the splenius capitis. Splenius means bandage in Greek. And you have a capital division and you have a cervical division. And you'll see that a lot of the muscles in the neck have this relationship where you have a capital, a cervical, and as we'll look at, you have a thoracic and lumbar division as well. You can see that it originates at the spinous process, and then the cervical division goes to the transverse processes of the upper cervical spine, and the capital division goes to the lateral. And so it has this medial origination and a lateral insertion. So you can see the cervicus here and the capitis there, and they're just tucked right underneath one another. As we go deeper, we come to our next muscle that we've already dealt with in terms of the shoulder as a shoulder elevator and downward rotator of the scapula, the levator scapula. And so this one attaches, it originates on the superior angle of the scapula, and it inserts on the transverse process of C1, C2, C3, and C4. And so it has a strong influence on lateral flexion, and because of this really lateral attachment, as we'll look at another slide, is involved in cervical rotation or head rotation to the right. When we look now even further into our muscle groups, we have three primary groups we're going to explore, and we'll look at this suboccipital group, so just below the occipital part of the skull. And these are involved in controlling capital movements. So you have a whole set of muscles that are dedicated to just capital cervical relationship. And you have two primary muscle groups that we're going to talk about in length when we look through the cervical and down to the lumbar spine. The erector spinae group, which is made up of the spinalis, longissimus, and iliocostalis. And then the transversal spinalis group, which looks at the semispinalis, multifidus, and rotatories. So we'll look at the erector spinae first, and you have the three, iliocostalis, longissimus, spinalis, and those are listed from lateral to medial. And you can use an acronym like I like spaghetti or whatever you want to supplant for S. And when we look at the erector spinae group, as I said, you have a lumborum or a lumbar group that goes from sacrum up through the thoracic spine. You have a thoracic group that originates on the thoracic spine and goes up to the cervical spine. You have a cervical group that goes from thoracic to cervical, and some of these muscles have a capital group. So you can have some muscles like longissimus that go all the way up from the sacrum and make itself all the way up to the base of the skull. And so they control everything from tail to head. You can see here spinalis is an interesting muscle. It does go from spinous process to spinous process. And it does that both in the cervical region and the thoracic region, and that is a straight up spinal extensor. When you look at iliocostalis and longissimus, they have an interesting orientation where they have a medial origination and a lateral insertion. And so they kind of go up like in a V. So they go from medial to lateral, and both of these do that. Just iliocostalis goes longer. Longissimus goes out to like the transverse process and maybe the medial part of the rib, whereas iliocostalis is attaching right next to it at more of a just lateral to the longissimus. And we'll talk more about that orientation, but I just wanted to bring that up right now in terms of its effect on rotation, that the erector spinae will do extension and ipsilateral lateral flexion. So if these guys are contracting on this side, they'll bring you to the right. But what they also are involved with is spinal rotation. And so both the iliocostalis and the longissimus, because of that orientation, they do ipsilateral rotation. So the right side will turn the head to the right. Conversely, we look at the transversal spinalis group, and what's unique about these guys is that they have a lateral origination and a medial attachment. So they're kind of coming up and they form this Christmas tree-like pattern. And the only big difference between these muscles is that you have some that span like 4 or 5 vertebrae. You have some that span like 2 or 3, some that span 2, and one that spans 1. And so that's all that differs between these, but their function is exactly the same. It's just, are they controlling 3 or 4 joints, or are they controlling just one joint? And so that's your multifidus, your rotatories, your semispinalis musculature. So look at the semispinalis first. You have a capital division, you have a cervical division, and you also have a thoracic division, so similar to the erector spinae. And this does extension of the spine. It will do lateral flexion on the same side, and this will do contralateral cervical rotation. This will attach here at the spinous process and pull this way to turn the head to the opposite side, to the left, and we'll look at that in a little bit. What's next in that group is a suboccipital group, and again, these muscles just are just below the skull. All of these, except for the obliquus capitis inferior, these are all capital muscles where they attach to the capital and either C1 and C2, and that's it. That's all they span. So it's a very short group of muscles. These are involved in ocular stability, trying to keep the head and eyes level. And this is how you're able to do cervical movements independent of capital movements. Obliquus capitis inferior is included here. It does mostly cervical rotation and lateral flexion, but you can see that it originates at C2 to C1. And these are really deep. These are the deepest set of muscles that are in the base of the skull. You can see the orientation here. Rectus means straight, so you have rectus capitis. These are relatively straight. Think of these as like the abdominals of the back of the head. And then you have your obliques, and think of these like the obliques of the back of the head. They come at an angle, and you have your obliquus capitis superior here, and it does more lateral movement, so think of side bending, and you have your obliquus capitis inferior at this angle. This is doing more lateral movements. And so this is a great chart. It kind of shows all of the muscles. So you have four sets of the muscles that are in the back, and then you have two, the rectus capitis lateralis and rectus capitis anterior, that are in the front. And we'll look at those when we look at the anterior neck musculature. But you can kind of see here that they're almost all involved in lateral flexion, and this is looking at either the atlantoaxial joint or the atlantooccipital joint, and you can see that a lot of these cross both of those. So this is the fine head movements that are occurring in the suboccipital joints. From a lateral view, we can see the sternocleidomastoid and the trapezius and the levator. And as we pull some of that tissue away, what you would reveal are these scalene muscles. You have an anterior scalene, middle scalene, and posterior scalene, named so for their attachments into the ribs. So this is more anterior, this is middle, and this is posterior. You can see the posterior scalene comes down to the second rib, and the anterior middle come down to the first rib. And these are purely in the lateral, right in the frontal plane, and they are purely lateral, and so they are highly involved in lateral flexion. The anterior scalene, because of its more anterior attachment, can pull a little bit into cervical rotation and maybe a little bit of flexion, but that's not a normal part of its function. You can kind of see here that these guys are going to do more just pure lateral flexion. That's their biggest moment arm. And this guy here, because of its anterior translation, can do a little bit of rotation and flexion if the head is in the right position. As we move to the anterior aspect, we start to see, we removed the platysma, we removed all the supra and infrahyoid muscles, and you're left with four muscles in the anterior aspect. Your first muscle is the longus colli, and its affiliate, the longus capitis. So if this is like the erector spinae where you have a cervical and a capital, these muscles are kind of set up in that same arrangement where the longus colli is, the longus capitis is just a continuation of the longus colli. And so you have these cervical flexors, they can do rotation, and the longus capitis is going to do that capital flexion, bringing your chin into your throat. And then you have the two other suboccipital muscles in that suboccipital group, but they're not behind the occiput, they're more in the front. And you're going to have rectus capitis anterior, so it's going to be able to do spinal capital flexion. And you're going to have rectus capitis lateralis, and as the name implies, it's going to do lateral flexion. So you can kind of see all the attachments of the anterior musculature, mostly onto the transverse processes of the cervical spine, and then coming from the anterior body. So this longus colli is like the core of the anterior neck. It's like the psoas of the hip. And I just have this slide here to kind of help you appreciate the imbalance that exists between the extensors, the image you see on the left, and the flexors, the image you see on the right. The normal resting position for gravity is cervical flexion. And so the reason why these muscles are so much more developed and bigger in size is that these are constantly fighting gravity. Your head wants to come down into spinal flexion, capital flexion, spinal flexion, head forward, more than it wants to naturally come back into extension. And so you don't need a lot of big muscles to bring you forward. It's like what internal rotation is to the hip, cervical flexion is to the neck. And so you have these muscles that are more involved in fine motor control. You don't need to generate a lot of force. The force generation aspect is here in the posterior musculature. And when you look at from an inferior view at the base of the skull, so this is front, this is back, and this is looking from straight up through the spine, as you can see the attachment points. And this line here represents the axis of rotation for flexion versus extension, and this here represents the axis of rotation for lateral flexion, either left or right. And remember, whoever has distance on their side is bigger control in that movement. So you can see trapezius is our most powerful neck extensor, followed by semispinalis capitis. And although the attachment's more broad here, this muscle is extremely thick, right? Again, the third largest muscle in the body. So the trap, which we learned as a shoulder muscle, is the most powerful extensor, and it's a very powerful rotator as well. And then you have your distal here, your sternocleidomastoid, which is we said had a big lateral component. You have your splenius capitis, and then you have your longissimus capitis should be here in place of sternocleidomastoid. Your longissimus capitis that comes down and pulls laterally into that. Then you have your suboccipital muscles here, and you can see that they're involved in lateral flexion. So you can see that there's a lot of intrinsic muscles that are new, but we have some of our muscles here that are somewhat familiar to us. So that's a really thorough, a lot of information there in terms of cervical spine. And I think the big takeaway is making sure you appreciate who's a agonist and antagonist for certain motions and where that movement's coming from. Is it coming from C0, C1, C1, C2, and the rest of the cervical spine? And then which muscles are working as agonists in that? So for instance, trapezius bilaterally is working as an extensor along with SCM, and all these muscles are actually working. But then when you start looking at rotation, these guys are going to be rotating one direction, and then these are going to be antagonists to each other, and so on and so forth. So hopefully that was helpful. And we'll investigate the spine some more in the thoracolumbar region.